Hi, I'm Sarah SDX, author of Don'tCookYourBowls.com, a lighthearted guide to male fertility. I've decided to travel far and wide to seek out the top experts in the field to find out what causes male infertility and, more importantly, what can be done about it. Today I want to talk about genetic causes of azoospermia. About 15 to 20% of men who have non-obstructive azoospermia have an underlying genetic cause. So go ahead, blame your parents. I talked to Dr. Werthman about what are the treatment options. Are there things that can be done to help these men become fathers, and what are the success rates? Let's see what he had to say. All right, well, let's switch gears a little bit and go into non-obstructive. So this is where we're having a problem producing sperm in the first place. What are some of the causes of that, and are they correctable? What can be done?
So the answer is that some of the causes are correctable, some aren't. But the good thing, and the take-home message should be for this, that most men with non-obstructive azoospermia still produce some sperm, and most men can still be fathers, even if they have a production problem. So let me start by answering the first part of your question is as to what causes this. So some of it is genetic. About 15 to 20% of men who have non-obstructive azoospermia have a genetic related issue, meaning they either have a deletion on one of the genes that causes or that controls sperm production on the Y chromosome, or they have an issue with their karyotype, meaning their chromosome complement. They might have something called a translocation, where the part of one chromosome breaks off and switches places with another chromosome, and that can lead to sperm production problems. But it's important that we check these things, and the reason is that sometimes it tells us that there's a really good chance of sperm, sometimes it tells us that there's a really bad chance of finding sperm, I should say. But also we want to make sure that if we do find sperm and we use them to make a baby, that we're not going to make a baby that's genetically abnormal, so we need to check certain things and make sure that we know what's going on before we just go ahead and proceed. So clearly the genetic issues aren't correctable. Going back to the genetics, because I left out a big one, which is Klinefelters Syndrome.
Okay.
Klinefelters Syndrome is a situation where a man is born with an extra X chromosome, an extra female chromosome. So they have a Y chromosome, which makes them men, but they have two X chromosomes, and the addition of the extra X chromosome causes a dysfunction within the testicle, so the testicle doesn't work quite as well. And this has been another miracle of modern medicine. Until this generation, men with Klinefelters were sterile. But we now know that in about half of men with Klinefelters, we can actually go into the testicle and find sperm.
Wow.
So with IVF, half of the men with Klinefelters can be treated. And Klinefelters is very common. It's 1 in 400 babies born, male babies born, have Klinefelters.
Wow,
I mean, that's a big number.
Common.
Very common.
Wow. So are these guys diagnosed as babies? When do people find out that they have Klinefelters?
It's pretty unusual for them to get diagnosed as a baby. And the reason is because the way to find out if someone has Klinefelters is you have to do a karyotype, this blood test that I mentioned earlier that looks at all the chromosomes. And there'd be very few reasons why you would want to do this on a baby unless something else was going on. So you don't usually find out about Klinefelters until these boys go into puberty, and they might have delayed puberty, some of them. Others won't have delayed puberty, but we find out about them when they come in because they've been trying to conceive for quite a while and they have zero sperm. And then when we examine them, they have a pretty characteristic appearance on exam. Usually these patients are on the taller side, and the testicles are very, very small. They're usually the size of grapes.
Oh, wow.
So that kind of
tips you off a little bit.
Tips us off
it's a little
that
tiny,
that patient has Klinefelters. But it's another important point that as small as the testicles may be, still half of them have sperm.
Wow. Little bitty guys making babies.
Right, exactly.
Oh, that's good. That's amazing. So same procedure for taking it out. You go in, look at a microscope, find these sperm, abstract them, and then use ICSI to go ahead and do an IVF cycle?
So in general, yes, the procedure we use to take the sperm out in the non-obstructive patients is a little bit different than the procedure we use in the obstructive patients.
Okay.
So for the guys with the blockage, where it's easy to find sperm, that I do in the office under local. For the guys who have non-obstructive azoospermia, in those patients, it's harder to find sperm.
Okay.
Because the testicle isn't producing sperm all over the place. It's only producing sperm typically in small pockets. And then it becomes critical that we find one of these pockets. Well, since the tubules in the testicle, where the sperm are produced, they're called the seminiferous tubules, they're microscopic. You can't see them to the naked eye.
Okay.
So if you just went ahead and took a biopsy or took a random piece out, you might not get a piece that has sperm. So a procedure's been developed whereby we use a microscope when we open the cover of the testicle, a much more powerful microscope, where we can then see the individual tubules.
Wow.
And because we found is, in men who are making sperm, the areas that produce sperm look different than the areas that are scarred and don't produce sperm. So we can use the characteristic of the appearance of the tubule, how big it is, how thick it is, what color it is, to try to differentiate between the areas where the sperm are and the areas where there is no sperm. And by removing just the little pieces that look best, that might contain the sperm, we accomplish a number of things. Number one is we double the chances of finding sperm in these men. So for a non-obstructive azoospermic patient, before we started using the microscope, the chances of finding sperm was about 30%.
Oh.
With the microscope, it's between 60 and 70%.
Wow.
The other thing is I can do a lot less damage to the testicle because I can take much smaller pieces.
Right.
You know, it's like trying to find a needle in a haystack. It really helps if you have a magnet.
Right.
So if you're trying to find an area that looks different from a different area that's microscopic, if you have a microscope, you can differentiate the areas.
Wow.
And
Wow. So is this microscope like goggles you wear, or something you put over the? How does this microscope? What does it look like?
It kind of looks like a periscope on a submarine.
Okay.
Where it's on a stand and it kind of drops down over the patient, and you look through it, and it's got handles, and it really very similar to a periscope.
Oh, okay.
And this thing can enlarge the field by 10 to 15 times.
Wow. Wow.
So it really lets us have a good view.
It seems like this is something then it's really good to have someone who's experienced, so who can really look and say, yes, I've seen this. This looks like an area that has sperm versus one that doesn't. It sounds like this might be good for an expert to be doing this kind of surgery. So when you have a severe case, you might want to go to...
Sure. And that's really a very important point. As we talked about earlier, there aren't a lot of doctors who specialize in microsurgery for male infertility. And traditionally, it's fallen under the auspices of urology. So if you have a blockage, any urologist probably can go and get some sperm. But if you have a production problem, if they're going to go and just do that same random biopsy, you have a 30% chance of having sperm found. If you go to a doctor who's experienced at doing these microsurgical procedures, and it takes a lot of experience to learn how to do this, because not only is it you looking for the tubules, but then you have to search for the sperm once you take out the tubule. So it becomes an issue of you have to have enough experience correlating where to look and how to look.
Right.
And how much to do and how little to do, because at the same time, we don't want to damage the testicles too severely. So I know some of my colleagues, they kind of go to town on the testicle and really tell patients, we're going to turn this thing inside out to find a sperm. Well, in my experience, you don't have to go that far. You don't have to cause irreparable damage, because my success rate is the same without having to go quite that far.
I see. I almost picture you with like a safari hat, like you're going to go find these, you know, rare, endangered sperm and hunt them out and capture them and bring them back to the San Diego Zoo or something.
It's a good image. It's just a surgeon's hat.
Yeah. Well, that's quite a service you do. That's remarkable to be able to, you know, give these guys so much hope and opportunity to be able to father their own biological children when, you know, probably many of them have been told that it would be impossible. That's
really the most rewarding and satisfying part of my job, is to take people who have really been told that they can never be a father, or have had multiple procedures that have been unsuccessful, and go in and do something and actually make that difference and help them have a baby. You know, we're looking around the office earlier, there's a big thing of cognac, Armenian brandy over there. That was from a patient who was trying to conceive for 13 years.
Wow.
And had multiple procedures and saw multiple doctors, and we went in and we found a few sperm, and he had a baby, and he was so thankful. I mean, imagine, he spent 13 years of his life going through this.
Wow. Wow, that is so touching. So let's recap with some of the key takeaways. First, if you've been diagnosed with a genetic issue, there are still treatment options available. However, it is important to review your genetic tests, as a lot of the results of these tests can give indicators of how successful or how likely you are to find sperm during a sperm extraction. Second, if you do decide to go in and do a sperm extraction, it's very important to find a surgeon who's skilled in microsurgery. It increases the chance of success when they have the microscope and the ability to recognize the areas of the testicle that are healthy and producing sperm versus those that are not. If you are in the LA area, I totally recommend Dr. Werthman. He's got years and years of experience doing this surgery. He's very easy to work with and takes time to explain things to you and help you to sort through what your options are and your decisions, what your potential decisions could be. So I've included his information below. And if you're not in the LA area, go ahead and you can write him, email him or call him, and I'm sure he'd be able to provide either a recommendation of somebody in your area or potentially give you some advice over the phone. I've also included below our website, www.don'tcookyourballs.com. I've written up some articles on these different genetic conditions that can cause azoospermia and some of the details to help you sort through what is the condition, how did I get, what are some of the details. So go ahead and check that out, www.don'tcookyourballs. Thanks for tuning in. I look forward to seeing you next time.